Hi dear all, I am Kalaivani Vetrivel from Department of Pharmacy Practice, SNS College of Pharmacy and Health Sciences. Today let's have a case. Description on atrial septal defect, ASD. An atrial septal defect, ASD, is a hole between the top chambers of the heart, atria. This is very common in children with congenital heart defects, 30 to 50%. An ASD is classified by its location on the atrial septum, which is the wall between the top two chambers of the heart. In most, blood will flow from the left to right side, which means oxygen saturations will be normal. Types: secundum ASD, 50 to 70%. This most common type is located in the upper, thicker part of the septum. Most close spontaneously without intervention. Patent foramen oval, PFO. RPFO is a small hole in the upper part of the atrial septum and is a part of normal fetal circulation. A foramen oval usually closes after birth.
Don't know why
when it is
congenital
present
heart
after
defects
birth,
occur.
it is called
Family
a
history
PFO.
may play a role in
It
some
is
heart
present in
defects.
75%
Children who have
of
genetic
newborns,
disorders such as
which is
Down
considered
syndrome
a normal
often have congenital heart
variant.
defects.
Approximately
Smoking during
17 to
pregnancy has been
35%
linked
of
to
adults
congenital
have a
heart defects,
PFO.
including
Primum
ASDs
ASD,
and VSDs.
30%. This type is located in the lower, thinner part
In
of the
heart,
atrial
we'll be
septum
having
near the
atrial
tricuspid
and
valve.
ventricular
Primum
septums.
ASDs are usually a part
ASD
of
is
partial
nothing but
or
atrial septal
incomplete
defect, where the
atrioventricular
hole
canal
present in the
defects,
septum of the
CAVSD.
atria, and ventricular
Sinus
septal defect,
venosus
that is
ASD,
VSD, is nothing but a
10%,
ventricular septal
located in the
defect.
atrial
The birth
septum
defect
near
in which
either
there
the
is a hole in the
superior or
wall that
inferior vena
separates the
cava.
two lower chambers
Defects
of
near
the
the superior
heart, that is
vena cava,
ASD and VSD.
SVC, are
There are
commonly
many types
associated
of
with partial
atrial
anomalous
defects.
venous
And
return,
what are those types?
CTAPVR. Unroofed coronary sinus. This is a hole between the atrium and coronary sinus. The coronary sinus returns blue, deoxygenated blood from the heart back to the right atrium. Often a left-sided SVC will be present. A fenestrated ASD is a defect that has many smaller holes. Physical exam, symptoms. Most children do not have any symptoms. Many children with ASDs will have a thin body habitus.
To
Murmur,
cure this heart
grade 2 to
disease,
3,
that
6
is
systolic
ASD device
ejection
closure
murmur
for the
heard
small
best at
holes
left upper
and
sternal border.
surgery
Second heart
in
sound,
none other case.
S2, is fixed and widely split. Diastolic
ASD
rumble may
device
be present.
closures
A
MS
murmur may
is
not be
used
audible in young infants.
to cure the
Diagnostics, chest X-ray. A large heart with prominent pulmonary vascular markings may be present. EKG, not used to diagnose. Patient may have evidence of right atrial enlargement. Echocardiogram, diagnostic. Medical management, treatment. Most secundum ASDs and PFOs close spontaneously. ASDs can be closed surgically or with a device in the cath lab. See ASD repair. Medications may be needed to treat arrhythmias if they occur. Cardiology follow-up is needed. Through childhood. Long-term outcomes, normal lifespan and developmental outcomes in the absence of other congenital heart disease. Atrial arrhythmias, flutter or fibrillation, may occur in adults with or without surgery, occasionally associated with varying degrees of heart block. The procedure was performed as previously described. 7, 19, 20 in our institution. ASD closure was done under general anesthesia with orotracheal intubation and T guidance from 1998 to 2005. Starting in 2005, TTE guidance was used in all patients, regardless of age or ASD characteristics. TTE-guided procedures were performed under deep sedation in spontaneously breathing children less than 12 years and under local anesthesia in other patients. In our study, 207, 61.6%, patients, all managed before 2005, had general anesthesia and 219, 65.2% patients, all patients since 2005, had TTE. Guidance. In patients with pulmonary arterial hypertension, criteria for ASD closure were pulmonary vascular resistance less than 15 Wm2, persistent. Left to right intraatrial shunt, QP, Q's ratio greater than 1.5, and symptom onset within the past 6 months. 21 ASD sizing was based on the fluoroscopic assessment.